This video provides information on executive dysfunction and demonstrates how nurses and other healthcare professionals can use the Brief Evaluation of Executive Dysfunction tool to identify this phenomenon among older adult patients. Understanding a patient's ability to safely and adequately care for him or herself in order to remain safe after discharge is critical in the discharge planning process. This capacity is not necessarily captured in routine testing for cognitive status.
Mr. George is a very interesting 89-year-old man. He is someone who lives with a partner who he's lived with for many years. The diagnoses include pneumonia. However, this is his third hospitalization for pneumonia in the last 5 weeks. It's just a red flag for us to really be taking a look at him. He also has high blood pressure, hyperlipidemia, and there is some issue of cognitive impairment, but it's not been worked up completely at this point. He does have some visual changes, but he wears glasses, and that seems to help. And he does have a hearing impairment, however, he also wears a hearing aid. His medicines include Namenda, lisinopril, aspirin, and Aricept. The issues that Angela came to tell me about were several that are very common in this particular hospital, and they included several falls. And could you just describe a little bit more, Angela, about what happened, why you thought it was so important to get in touch with me?
Somehow he's not able to understand the use of the call bell. We have told him several times to use the call bell. He's able to say, to explain and to verbalize what he has to do before, getting out of the bed, or what he has to do to call for assistance. But yet, even after he's much better and he's much stronger now, he has still fallen. And another reason is that, on setting him up for him to take a bath, on coming back, like half an hour after, so he's still sitting there looking quite perplexed, like he doesn't know what to do. So we're concerned if there's something else going on, if he's impaired cognitively.
As a result of that, Angela asked me to do a little bit more of an assessment. So, Mr. George, we're going to spend some time together this morning me asking some questions and doing a few different little tests that'll help me understand what your abilities are and what some of the problems are. I need to ask both you and your wife a couple questions, though. So, when you're getting dressed in the morning, is there any problem with you putting yourself together? Is there any problem with bathing?
No.
No? Okay. Is there any problem with putting your clothes on?
No.
And is there any problem with selecting the correct clothes for the weather?
No.
Okay. Do you ever have any difficulty when you're shopping?
Of what nature?
When you're shopping for food, do you get all the items that are on your list?
Yeah, I have a written list and I work from it.
Okay. And are there any times when you've thought that you came home and you weren't given the appropriate amount of money back, appropriate amount of change?
No.
No. Okay. Have there been any times when you've gotten lost when walking outside?
No.
No. Okay. Any difficulty with banking or taking care of your finances?
No.
Okay. Have there been any times when there might have been a second notice for a bill to be paid?
Yes, occasionally.
Okay. So today I'm going to give you 3 different tests, and the tests are from this point of how you're doing right now. And for this part, I'm going to ask Miss S to leave the room, and we'll certainly have her come back after you've done the test, and we'll talk. The first thing I'm going to ask you is, I would like you to draw me a clock and set the hands of the clock on the time 1:45. Okay. Okay. I'm going to put this aside for a minute. And I'm going to do something on this part next. And then I'm going to ask you to go back to the clock. Now what I'd like you to do is I'd like you to copy that drawing over here for me, if you would. And I don't know if you need your glasses for this or not.
No.
Okay. Okay, do you want me to move up the chair a little bit?
Yeah, so the elbow could be on the table.
Sure, absolutely. I know. You know what? This is one of those tricky pens. There you go. Okay, now I'm going to do a different test with you. I would like you to tell me all the words you can that start with F. F is in Frank.
Fellow. Fallow.
Okay.
Think. Four-flusher. Foible. Flaxseed. Frantic. Forthright. Fix. Fly. Float. Falter. Fabulous. Foible. Frankness.
Okay, I'd like you to stop now. Okay, now I'm going to ask Angela to do this with you with two other letters. Okay?
Sure.
Okay.
Yeah.
So the second letter is A. So A.
A is
Yeah.
first letter of the alphabet.
Yes, it's A as in apple.
Argument. Association. Abut. Attack. Accentuate. Alternate. Aide de camp. Align. Announce. Articulate. Abbreviate.
I'd like you to stop now.
The next letter is S.
X.
S. S as in sing, stand.
Sink. Search. Sand. Soap. Silhouette. Suburban. Socks. Sock. Simple. Sample. Settle. Soon. Sooner. Static. Stiff. Stumble. Is that it?
Oh, we
Oh,
can
did
certainly
it-
stop, or you can keep going.
Oh, I can go.
Actually, now I'm going to have you stop. Okay?
Yeah.
Okay. Now we're going to do something a little bit more challenging. I'm going to have you connect a letter to a number. Okay? And what I'd like you to do first is I'd like you to say the letters of the alphabet first for me.
A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T, U, V, W, X, Y, Z.
Okay. Now, I'd like you to say the numbers from 1 to 26 for me.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6.
Okay. Now, the hard part comes is I would like you to match the appropriate number with the letter. So if I gave you A, what would be the appropriate number that goes along with A?
1.
Okay. So I would like you to do that for the first 13 letters.
The first letter is A, the second letter is B, the third letter is C, the fourth.
I'm going to stop you here. What I need to have you do is to put the letter and the number together.
I see.
Okay. If I said A, what would be the appropriate number to go
A1,
along? Okay, can you do
B1, C1,
If A is 1, what would B be?
2,
Right. That's
A.
how, okay.
B, oh, A1,
Mhm.
B2, C3, D4, E5, F6, G7, H8, I9, J10, K11, M12.
Okay.
Is that it?
Okay. All right.
Thank
Thank
you.
you. Okay.
You're welcome.
Now, take a nice deep breath. Relax. Okay. How did you think you did on everything?
100%.
Well, you did more than 100% on the words. You were very good on the words. But on the clock drawing and this last test, which we call the trail making test, there were some things that were a little bit off on those. Were those a little harder for you? I'm not sure those came as easy for you as the words. What do you think?
I know that I hesitated
Mhm.
to get into everything after the first one.
Right. That was a little bit more of a challenge for you.
Yes, and I was sort of amazed that it was.
It was. You thought that would just be real easy, right? Okay. So I think this may be related more to some changes that are occurring in your brain and that are helping us understand why some parts of life are a little bit more challenging for you. We're going to invite Miss S back in to be with you. We're going to talk with her about the test results and what we think will be helpful at this point. These tests tell us that you have some changes in your brain that are making comprehension and carrying out tasks more difficult for you. Okay? So there are some things that we can do about that. But what I'd like to do, which I think will be very helpful, is to find out how you feel about this and how your wife feels about this, what I've just said.
I'm unperturbed.
Okay?
That's about all I can say. I mean, you may be noticing things which are different from what most other men of my age and background are doing. But I have not found these faults which you're describing to limit my life or experience in any way, so I'm ignoring them.
Okay. All right. Okay.
End of statement.
Okay. All right. And how about you, Mrs. George?
I just, I don't know. We know there've been a few problems with memory, so that might have something to do with it.
The tests are one part of an assessment for executive dysfunction, and
For what kind?
for executive dysfunction,
What's executive dysfunction mean?
that's a form of problems with the brain where people can have difficulty carrying out a task or initiating a task. Okay, and that's something that we're seeing in you. And what I'm going to do is to bring this to a geriatric team, our information. We're going to have a clinical social worker, your psychiatrist, Dr. Kennedy, myself, and Angela are going to talk about the test results and put them into a bigger picture. What do we think this means, and how do we think we can help both of you? And then Dr. Kennedy will be sharing these results with you later on.
That's very, very good.
Okay? All right?
Yes.
Okay. You're all right with
Sounds
that?
good. Sounds very good.
Okay, good.
Carol, when you were performing the test, the trail-making test on Mr. George, and he hesitated quite a few times here to explain, give him the instructions as to how to answer the questions. Is it a clear indication of executive dysfunction?
Not necessarily, but that's a very good point to bring out. Mr. George did have a hearing deficit, so part of it is compensating or trying to repeat the directions so that you're assured that it's not a hearing deficit that's a barrier there. The other part is speaking more slowly and reiterating certain highlights, and also seeking to have a definite example that clears the way for him understanding it. So when a person is very hesitant about answering questions or is taking a long time to answer any of the tests that we had, there can be a couple different reasons for it. First, we have to make sure the person clearly heard what was being said to him. We have to make sure that the person is able to focus on the topic at hand. The trail making test is very complex. It might take a couple examples before the person would be able to go forth and do it. And the minute they start actually trying to put the numbers and the letters together is when the clock begins to. So they may end up with a shorter time period to be able to react to that. There are absolutely times when I will stop testing a person if the person's becoming too aggravated, irritated, or frustrated. It doesn't help us if the person is so upset. It's not going to give us any more information, and it's not going to help us be able to help that person. So it's very important to have that kind of time and environment framework, because we need to have that support the patient who's doing the testing. The other very important and good part was that Mr. George's partner was willing to leave the room when we did the testing.
Why is that important?
It doesn't seem to be so important on the outset, because you kind of think, well, the partner may make Mr. George a lot more comfortable. What I found actually take place is that the partners, the spouses, the aides, the caregivers can feel as though they need to help the person, either by interjecting and saying, oh, you know that, of course you know that. And sometimes that can be very upsetting to the patient, and it also means that you have to get the person's attention to come back to the center point that you want them at. The issues that I found when I talked with him is he's very sociable, he's easy to engage, he has very good eye contact, there's no issue of hallucinations or delusions. His test results are so close, many of them are on the border. He's a very educated man, so it was helpful for me to have this information, but I also wanted to have Dr. Kennedy's input, so I've asked Dr. Kennedy to see him, and I'd like him to share a little bit about what his findings were too.
I repeated the test of executive dysfunction. He clearly has impairment. And just as you said, this is a man who's a pleasure to work with. He's engaging, he wants to please, well-educated, quite articulate. So his executive dysfunction is probably worse than appears on these tests, because he's so good at the verbal measures. I went another step and asked him questions to test his memory using a memory impairment screen and the mental status examination. In both instances, his impairment was more than mild. So part of the issue we face with him is that he's very, very skilled, no communication problems, so you don't perceive the level of impairment that he actually experiences. He doesn't perceive that level of impairment either, and neither does his partner. So that's one of the problems I think we're facing. How do we prepare them to cope with impairment that they're not fully aware of? My other assumption is that one of the reasons he seems to function so well at home is he's in such a stable environment. Put him in a novel environment, he's going to have problems, which is what you've been seeing, Angela.
And that brings us to one of the more hard experiences is having a patient and a caregiver who aren't quite where we would like them to be. They're not quite accepting of the problems and the issues, and they may not even know that much about what the future problems are. So how do you, as an inpatient social worker, tackle this problem, and what advice could you offer us as team members working with a patient and a caregiver like this?
How much do they know about what we're talking about? Because we're assuming that they know and they're denying, but I'm interested in what you've actually said to them. What words have you used? What have you described in terms of prognosis? What can they expect?
When I tried to gently suggest that yes, there were some impairments, and the impairments were not simply explained by age, probably not due to the recent pneumonia, they tended to downplay that. I did say that this could be Alzheimer's disease, that we should treat you as though it is, that I'd like to see you again and work with you on this. Mr. George says, I don't think it's Alzheimer's disease, but he's certainly willing, and I think he means this, to come back and see me. Now, of course, I need to call the primary care physician as well, because I have a sneaking suspicion that the diagnosis may have been voiced. That's not always the case. And to help them prepare for the future and to give them the sense that they're not going to be alone in those preparations, we need to have an additional discussion about it.
Is there too much risk to tolerate them going back to the same situation? Is the risk of readmission too high if there's no one who's managing medication? Or can we tolerate more of the same? Because he's had 3 admissions. That's a problem.
I think the other choice that we can certainly offer them is to have a visiting nurse service go in to help assess a little bit more of what does this home look like, and to further give information back.
I think being explicit with our goals of care would be very important. There are 3 things that I think we want to deal with. We want to deal with their medical needs and what's going to be a safe care plan. We want to deal with the losses that both of them are coping with and the additional responsibilities we're asking Mr. George's partner to take on. And we want to engage the support systems that may be available to help him stay at home safely. And that's something that I think a community social worker would be useful in doing, because the systems are complicated and navigating that shouldn't be something they need to do by themselves. And I think we want to make clear to them that they have partners, that we're not going to abandon them, but we're also not going to abandon him to his illness. If he's making choices that are poor, that are putting him at risk, I think we need to say that too, that we will not do that either.
I think the next step will be Angela creating a meeting with the partner and Mr. George, inviting whoever you would like on the team to be there with you, and going forward, setting up a discharge plan which allows Mr. George and his partner to choose how much they would like. Dr. Kennedy is going to be following up with him in the community, and we'll keep our fingers crossed. But thank you very much for all of your effort and time.
You're welcome.
Good work, everybody.
Thank you very much.
Executive function is a set of higher cognitive processes which includes concept formation, flexibility, and self-monitoring. It implies that the person can start, sustain, and terminate a task through self-monitoring. It also means the person can avoid extraneous details, and stay on the topic. When executive dysfunction occurs, the person will have difficulty sustaining a task, difficulty completing it, will get distracted, have problems taking care of themselves. Memory and communication are located in the cortical or surface structures of the brain, but the complex task of concept formation, flexibility, self-monitoring lie deeper within the brain structures. Sometimes because of microvascular strokes, because of traumatic brain injury, or other problems, the connections within the brain that would lead memory, communication, and planning to connect become disrupted. So executive dysfunction is a disconnection syndrome whereby the critical circuits that we need in our brains to carry out our tasks and take care of ourselves become disrupted. Executive dysfunction is a form of cognitive impairment. And in fact, with persons with dementia, especially in the advanced stages of the dementia, executive dysfunction is uniformly present. However, a person can have executive dysfunction and nonetheless have intact memory and intact communication skills and be fully oriented. So it's important to recognize that even when you're working with a patient who seems entirely intact, there may be executive dysfunction under the surface. Executive dysfunction can be the first manifestation of dementia. It can also be present for some time before the dementia actually becomes manifest. But in all cases, as dementia advances, no matter what the dementia diagnosis, executive dysfunction sooner or later will be a problem. There are two reasons why the detection of executive dysfunction is critical in the hospital setting. The first is because it may not be apparent in the context of a person who is able to communicate adequately and seems unimpaired, and yet it imposes a risk to the safety of their discharge plan because they may not be able to fully adhere to the discharge plan and take care of themselves when they go home. This is particularly an issue when the person lives alone, doesn't have someone available to cue them, to monitor their performance, to help them initiate and continue the task. Secondly, most often the global screening measures for cognitive impairment, like the memory impairment screen or the minimal status exam, don't necessarily detect executive dysfunction. So the most commonly used screening instruments would potentially ignore the presence of executive dysfunction. And again, if we ignore that, then we're discharging our patients with a less than fully safe discharge plan.
I think what happens is healthcare professionals are not aware that the executive dysfunction really impacts activities of daily living. It impacts how we groom ourselves, how we dress, our ability to clean up our environment, our ability to take care of banking, take care of our finances, write checks. It also impacts shopping, meal preparation. It's going to really impact what happens in the person's home. If healthcare professionals and nurses are in a pivotal position to do this, can take a look at what's happening in the hospital setting regarding that patient's ability to give information, to process the information, how they're putting on their gown, are they listening and able to follow through with using the call bell and using other types of instruments that we may give them. That's a first clue, a first tip-off that this person may have executive dysfunction and may need a further workup. The 3 tests that we use are representative of a group of tests that have been used to elicit dysfunction in executive abilities. And they center on a very complex type of problem solving. They center on a sequence of events that the person has to put into sequence, be able to react to, and know when to end. The clock drawing is a test that requires the ability to actually consider what a clock looks like and then to be able to draw that. And then a complex time. 1:45 is a time that you don't see on a regular clock. You're not going to see 45 on a regular clock. Using the oral trail making test is also very complex. We don't usually put numbers and letters together, and while it may be a little bit easier to do that on paper, it's certainly much harder to do in your brain, in your head, to do that. And it involves a great deal of sequencing in that particular test, and that's why it works well to bring out if a person has executive dysfunction. The third test, the word list test or a verbal fluency test, is a type of test that is sometimes related to the quantity of education that a person has, what they've done in their life, as was certainly true with Mr. George, but it's also something that people have a relative fund of knowledge about. We know that most high school graduates, if they have average intelligence and do not have a dementia, can give us at least 30 words in 3 minutes.
When you suspect executive dysfunction, just as when you suspect any form of cognitive impairment, all the laboratory tests and examinations need to be completed to detect any reversible cause. Nonetheless, executive function may be persistent, may be there, even when the reversible causes are absent. Now, if you're testing for executive function, and obviously we're recommending that be the case, you need to be aware of several impediments to making an accurate assessment of executive dysfunction. First of all, the tests need to be administered in the person's native language. To ask them to participate in executive function testing, when they're having to translate to themselves is going to be a problem. Secondly, they may have to have sufficient vision and hearing to be able to execute some measures of executive function. And thirdly, because some measures of executive function require intact manual manipulation skills, if the person's had a stroke, if they have aphasia, if they have severe arthritis, they may not be able to complete the tasks.
One needs to make sure that the environment in the hospital room where the person's being assessed is quiet and filled with comfort measures for the patient. The patient should not be in pain, and more importantly, the patient should not be having a period of delirium or acute confusion. It's also important that the nurse feel comfortable enough that she does not have to step out into the hallway or meet other patients' demands.
There are 3 critical indicators of the need to assess executive dysfunction. First of all, the repeated hospitalizations implies that something went wrong after the person was previously discharged, and the question becomes, was executive dysfunction somehow involved? Second, obviously, are for older adults in whom any impairment, whether it's memory or attention, is not apparent. It may be important to assess their executive function as well, again because executive dysfunction could mean they're going to have difficulties caring for themselves when they return home, hence added risk for the hospitalization. And the third group of patients are those for whom there's no obvious problem with memory impairment, but still, even within the hospital, they're not able to follow the therapeutic regime, they're not able to take care of themselves properly, they may have falls or difficulty asking for the help. That would be an individual for whom executive dysfunction testing would be appropriate.